Well, welcome everybody. Thank you for joining us for this Carer Clinic Facebook Live on end-of-life care. My name's Jane Stanfield. I'm one of the associate practitioners for Dementia Carers Count. My background is in adult social care, developing and managing carers support services, mainly information services and carers assessments. But more recently, I have become a chaplain to a dementia nursing care home. So I'm seeing things from both sides, and I'm very interested in this subject. And I do some training with our staff on end-of-life care. And it'll be interesting to have this conversation with Raja. So those of you who are familiar with the Carer Clinic sessions will be familiar with Dr. Raja, but would you like to introduce yourself, Raja, and introduce the topic for us, end-of-life care?
Thanks, Jane. Thanks. Good afternoon, everyone. So I'm Raja. I'm an old age consultant psychiatrist, so I deal with dementia from the diagnosis to the end stage. And today we're starting to talk about end-of-life care in people with dementia. And as I normally do, or more recently started doing, it's better to start the session with a kind of a case vignette, which will make us understand some of the complex issues that are involved and how various people, professionals, could help in bringing together what is essentially a person-centered care, but being very empathetic to the person with dementia and their family who are going through a very difficult phase. So if I was to begin by saying that when I was a ward consultant in a dementia ward, we had an elderly gentleman who started showing signs of end of life, and we'll talk about those signs later on. And then the question was, would we as a ward be able to continue offering him support, or would we have to move him elsewhere? And at that point, we got in touch with the local hospice, who were very kind enough to bring their expertise in terms of providing end-of-life care advice on medications, on nursing care. We had our chaplain involved in trying to provide that degree of spiritual support, reflection to the family and to the gentleman himself. And we were able to provide what I would call as good quality death, as much as we talk about good quality life. In some ways, we need to apply that same principle towards what would be end of life for someone, and to the point that the wife of this gentleman was very keen for this to be a example of good service, good support, good care, and she decided that she would help us to make a video of what end of life care is all about, and that is what we're talking about. We're talking about, in terms of end-of-life care, the kind of treatment, care, and support for the people needing end-of-life. And it's kind of defined as the last 12 months of someone's life. So if someone is, if the prognosis is that someone was going to die within the next 12 months, then the end-of-life care principles of providing that degree of person-centered care and support. And the main aims are to achieve comfort, dignity, having emotional support, by which I mean emotional support for the individual with dementia, but equally emotional support for the family members who are going through a very difficult phase as well. So that is how end-of-life care would be defined, Jane.
Thank you. If our viewers have any questions or comments, please leave them in the chat and we'll try to answer them. We do only have half an hour and it's a huge topic, so we might not get to all the comments, but if we don't, we'll spend some time after the session reviewing the comments and replying accordingly as best we can. So moving on to the subject itself, can we look at physical comfort first, Raja? And it's obviously at any stage of care it's important, but what kind of things might we be looking at during end-of-life care?
So it's important to understand that end-of-life care is part of overall palliative care that is offered to people whose conditions, including dementia, where the focus of the treatment is not cure, but more kind of comfort and supportive interventions. So in a way, it would be easier to think of those physical signs if we had to think about what people with palliative care would be needing, experiencing anyway. So there could be things such as presenting with pain, and it may be that people with dementia may be able to verbalize their pain and talk about it, but more often than not, it would be more kind of non-verbal cues. It might be facial grimacing, discomfort in particular postures or when particular interventions are being provided, or even spurs of disturbed behavior, because pain is something that's very difficult to bear and it might lead to that. So pain is a very important sign. People might also be having problems in terms of communication. So they may be vocalizing sounds rather than coming up with words or full sentences, especially as we are now looking at an advanced stage of dementia as such. There will also be times where people are more sleepy, or sometimes they might be very agitated and restless, and it could be pain that's driving it, or it could be some degree of discomfort, whether it's with breathing or anything else. There could also be increasing episodes of incontinence, which becomes a problem as the dementia advances. So they could be the signs of there could be the signs of physical signs of things getting very advanced in terms of dementia. The other things to consider would be that as the dementia progresses, especially when people are towards the terminal stages of dementia, and I think it's important for all of us to be sadly aware of the fact that dementia is a leading cause of mortality in our country, and hence the reason why we need to try and make sure that people with dementia have the right degree of care towards the end of their life. One thing that will become more common is that they will be having repetitive infections. They could be treated with antibiotics, they might be treated with antibiotics, but they may not necessarily be free of infections because dementia has an adverse impact on immunity. So as the dementia advances, the ability of the body to fight infections does come down, so they will be predisposed to infections. One other thing would be that there will be significant changes in terms of nutrition and hydration. It could be for various reasons, but essentially, brain is struggling to manage essential bodily functions, eating being one of them. There might be difficulties to recognize appetite, or there might be difficulties swallowing, as swallowing requires a lot of coordinated activity to happen. So all of that will make us think that there is a lot of physical changes happening in the person with dementia, and therefore we need to be addressing these issues, not necessarily in a kind of a curative way, but certainly in a way that we could comfort and support a person with dementia.
Thank you. Yeah. So going beyond the physical comfort, we obviously also want to look at people's mental and emotional needs and their spiritual needs. And for me, the spiritual needs is far wider than religious needs, and it's about people's sense of who they are, their connection with other people, connection with things that are important to them in the world, and if they are religious, then obviously a connection to the other, whether it's God or gods or whatever. So all those we try and address as best we can, and I think thinking about what those needs might be and planning for those is important for people to have, maybe if they can have those conversations beforehand. Would you agree?
Absolutely, Jane. One of the things that I did when I was a very young doctor was to ask this very simple question, but it brought out a lot of reflective practices. Where would people with dementia want to die? And where do they actually die? And if you look at the data, it says different stories depending on who you ask. And people with dementia, they always want to die in their own homes. People or family members of people with dementia, they want people with dementia to be safe, and hospital is seen as kind of a safe environment. And therefore, if you look at data from that point of view, people with dementia do die a lot in hospitals. But that's the conversation to be had. I think we need to know from the person about what and how they see their last days of life to be. It's important to have that conversation at the very beginning when someone has got a diagnosis of dementia, as difficult as it may sound, as much of mental agony it might cause for the patient with dementia and their carers. Dementia is an illness that makes it difficult for the person to make decisions as their illness progresses. Therefore, where they have the ability and the intellectual faculty to make those decisions, we should provide them with every opportunity to make advanced statements about what they want to happen. What would they want to happen if they were to have recurrent infections? Would they want to go into hospital? Would they want to be treated with antibiotics every time? Would they want to be treated in an intensive care unit, or would they want to have ward-based care, or would they want just community support from GP and primary care services? And it's very important to consider those options, because we also know that transitions are something that people with dementia generally struggle with, and therefore for them to be in a very unfamiliar environment in the last days of death may not be something that would be very pleasant as an experience for them. We also have a duty towards supporting, preparing the family towards the eventuality of death from dementia. And it would be very difficult for them because they will have to come at it from a relationship role, but they also have to come at it from a carer role, and some of it might lead to a lot of conflicts, and therefore it's very difficult. And within families, I think it's important to listen to multiple views, because people will have different views on various things. So my sincere request and plea would be, as difficult as these conversations could be, and organizations like DCC would be able to help carers to have these conversations. But it's important to have those conversations at the earliest phase. It's important to have those conversations in smaller chunks so people with dementia could manage. It doesn't have to be one big meeting with 10 different people involved, which may not be something that people with dementia would be able to cope with, especially talking about a very sensitive topic like end-of-life care. But to try and do it in small, meaningful chunks, having people involved at those very important stages so they can be brought in to provide sometimes a professional, sometimes a personal perspective on various things. And then to try and document in a very clear, concise way, and to make sure that copies of these documents are available to health and social care professionals, because ambulance crew might go at a certain point of time, care homes might have various ways of documenting things, hospitals might be able to take documentation in. So I think it's important to make sure that the document is there in multiple copies and people have access to it. But it goes back to having those conversations at the earliest opportunity, so people with dementia will feel that they have actually had a say in what is a very important phase of their life.
Yeah, yes, and maybe also just having awareness, so that if suddenly something is said that oh, so and so, I would like something, or this is important to me, that someone jots it down at the time, because these conversations could happen at any time, and it might just be a very brief thing, but if we're able to capture something important that is said or is being trying to be said, and we're attentive and listen to what is being said, and then that can be added to the plan, can't it? And
yeah, absolutely. I do recall a time where I was looking after an elderly person in a care home, and interestingly, the care home had a very beautiful chapel as part of its building, and the kind of peace that brought this gentleman when he was taken to the chapel was what made it more comforting for him and for his family in the last few days of his life. And I think it's being aware of those kind of environmental things, because immediately you get a visual cue of where you are when you enter the chapel space. And that, for someone with a strong religious faith, it was very important to have that degree of even visual cue to support him.
Yeah. And music as well can be very important, can't it? The right music for the right person, and very individual, but it can be very important. So it's good to sort of record that sort of thing as well, as to what would be helpful, what would be wanted.
Yeah.
And that's all part of maintaining the person's identity there as an individual. This thing, Elvis songs or hymns or whatever it might be, you know, it is important to that person. So
anything that brings them that degree of peace, content, and a sense of familiarity, I think, would be very helpful. Yes.
People do often ask a question that I think it must be very difficult for you as a doctor to answer, but people often ask, how long has somebody got, you know, what stage are they at? How do you answer that? Are there some signs that people should be looking for, or
It is one of the most difficult questions to answer, Jane. It can be heartbreaking for families to be actually coming up to ask that question, and it would be equally more disappointing, if not more for the people, if I was say to them, I don't really know. But the honest answer is that none of us actually can predict with that degree of accuracy as to whether someone is in the end stage of their life, and if so, are we talking about days, hours, or weeks even, which is why the definition for end of life period is actually 12 months, and things could change in that 12-month period in many ways. But to kind of give a broad sense of understanding of what could be the potential signs of life, people with dementia will start to become more drowsy, spending a lot longer time in a sleepy state. They might have altered periods of consciousness. They might sometimes have sudden spurts of aggressive behavior, but generally they'll become very quickly exhausted because they won't have that physical stamina to continue with that kind of disturbed behavior. Their nutrition and their hydration, it will be very, very hard to maintain. Because they're not having that degree of alertness or consciousness, or not having understanding of eating and drinking, then it will be very hard. So the nutritional intake will be very, very poor. They will also start to have difficulty having conversations or even making sensible words. There'll be sounds rather than words to be expected at that point of time. Their breathing will start to become more and more labored and more difficult to manage, and it might also be that they start to become very cold to touch, especially with hands, because the circulation is starting to drop to that extent. So we need to try and make sure that none of these things are taken in isolation. It's not the presence of one or two things that will make us come to a kind of conclusion that someone with dementia is in their end stage. It's about having that degree of understanding of how things have evolved up to that point. What are the kind of other physical health conditions people can be experiencing and maybe contributing to some of those symptoms, and being aware that that this is not a definitive way of looking at things, but a most likely thing is what we are looking at. So in essence, none of us can predict with any degree of exact way of saying people are in end of life. But having a narrative and looking at the symptoms collectively would be a very helpful place to start.
And part of that might be having to consider and having a conversation with family about stopping certain aspects of care. Obviously care will go on to the end, but certain aspects, there may be a time when that's stopped. Is that something that is useful for relatives to understand and to
Yeah.
I mean, I'm thinking particularly in a personal capacity of when nutrition and hydration stopped, and understanding why that was quite important for me. So.
Yes, absolutely. I think there's always this misconception that people are not treated or treatment is being withdrawn. It's more about being proportional in terms of the interventions that we offer, but maintaining that high degree of standards of care with the dignity element attached to it. I think that's how I see that. People may not be offered antibiotics because at that point of time, antibiotics aren't really going to change outcome in any particular way. They might cause more adverse effects at that point of time if, for example, their kidney functioning is not that great. But what would be more useful to them is to not experience pain, and therefore the focus might be on providing those specific interventions for pain. Equally, it may be that people with dementia in end-of-life stage may not be rushed into an intensive care unit because they may not be able to withstand that degree of intensive, intrusive interventions. But they may be very helpful to have that degree of caring support from allied healthcare professionals who will be able to provide that degree of support, and or having palliative care specialists to come and advise about how to, for example, keep their lips moist, how to make sure that their personal dignity is managed. So all of those are very active interventions in terms of care and support, and some of it being medication-based interventions. But the emphasis is more on trying to minimize distress, but increase the degree of care and understanding of the person in the last stages of life. And there is an emerging concept called as namaste care, which is very commonly talked about these days, which focuses on modifying the environment, making it more sensory experience for the person in the last stages of life, because they can most certainly feel touch, even if it was very difficult for them to see or hear things. And we all know the concept of a loved member of family dying, holding hands of the person that they love, or someone from a religious background, and that is kind of seen as a good death, for want of a better word. So having that degree of sensory comfort would be more important than trying to have intravenous lines going in or a catheter going in, which will be increasingly distressing for the person with dementia in their end state. So it's important to have those conversations, and it's important to try and emphasize on the kind of reducing distress aspect.
Yeah. And touch and hearing might be the last senses to go. The emotions can go on even longer after cognition has gone completely. People can still feel comfort and love and those sort of emotions, can't they?
Yes, and I think it's important to. That's why it's important to talk to people, to hold their hands, to comfort them, whilst carrying out those very important decisions, be looking at do not attempt to resuscitate forms or respect forms, or however they are being described in various organizations. It's important to not lose focus on the fact that we are here to manage the emotions and the last few days of the individual.
And then we as dementia carers count, but also you as the hospital staff and everywhere, we would want to support the relatives as much as we can after death, and give them the right information and signpost to sources of support for the practicalities of arranging funeral and everything, but also looking at their own emotional health and their own emotional needs, and counselling or other things that are going to help. So we will have some links at the end. I think they're going to go into the chat to find other sources of support that people might need.
Yes, I think it's important to have those discussions about the support for the family member of the person with dementia, especially starting to get some degree of emotion-based support, whether it's formal psychological support or whether it's delivered through various other forms, including support from religion, faith-based organizations, voluntary sector as well. It's important to recognize various stages of grief that people will go through, and denial and anger being the very start of those of the grief reaction. As such, they are very difficult things to deal with, and therefore any degree of support will be very helpful. I would strongly recommend people to speak to their local mental health services, to their GP, to try and get that degree of carer support. I do know that there are organizations such as CRUISE which provide a fantastic bereavement counseling and support. So it's important to be aware of those things for carers. And sometimes it carers may be in quite a dilemma where someone with or who has started end of life care might suddenly start showing signs of recovery, and then it leaves them in a very very difficult state. You know, what was it? Was the diagnosis right? Was it being? Was everything being checked? And what do we do now? So it's important to understand that, as I said, end of life care is about the last 12 months of someone's life, and there will be fluctuations within that time period. And it is something that we will have to accept, that sometimes people do recover from what could be a very terminal event, but it doesn't mean that the care should change in any other way. The intervention should be proportionate, and the care should always be of a higher standard. So those would be the two kind of guiding principles to be taken into account. And I think it's important to have that conversation at the very beginning as well, when people talk about end of life care. That things will fluctuate, things might change, but at the end of the day, we are trying to provide comfort, dignity, and care to the individual with dementia, and support for the family member.
And to that end, our services team have designed a brand new live online session looking in depth at end of life care, and it'll discuss in much more detail the kinds of support that are available for carers. And that session will run over 2 weeks. It's starting on the 27th of July, if anyone's interested in signing up for that. So this just brings us to the end of the session. It always whizzes past, and we could have gone on twice as long, I think, Raja, couldn't we? Thank you so much for joining us, and thank you, Raja, for joining us again. Are there any final words you'd like to add, or do you feel you've...
I'd like to say just a couple of things. I mean, everything in medicine goes back to Hippocrates, but he said this very important thing, that you can you can cure sometimes, you can treat often, but you can comfort always. And I think that is the important thing that would underpin end of life care in people with dementia. And the second thing is that for all those carers who are going through this very difficult stage, please do find yourself a way to express that grief in a productive way, and that is very important, because it will, if we don't deal with grief in a productive, in a supportive way, then it might become more detrimental to our own mental health, and it will in some ways stop us from recalling some of the fond memories that we might have of the individual with dementia. We don't want to focus on the last few distressing days or hours or months even, but I think the more that we focus on the fond memories, the good memories that we've had, it will help us to deal with the grief inevitable. Thanks, Jane.
Thank you, Raja. Thank you. So I just want to add that we've launched our 2023 Family Carers Survey, and we know as carers you have very little time, but we would be grateful if you could share your experiences with us. We've online and paper versions to the survey, and we'll be happy to talk through or help you complete the survey over the phone if you'd like that. It should take about 15 minutes to complete, and you can tell us as much or as little as you like. So we'll leave a link to the survey in the comments. Thank you for watching, and goodbye.
Thanks everyone. Bye.